Well, welcome everyone to the EKG case for the week of July 16th, 2012. We've got, I think, an interesting case for you, and this is a case that I'm going to present. It was actually a case that I saw a while ago, but the reason I'm presenting it now is based on a handful of questions that I've gotten recently about this particular topic, and also a case that we had probably about 2 weeks ago, which had an almost identical finding. Unfortunately, that EKG was not quite as pristine as this one. So I'm going to share this older case with you to demonstrate the finding. Anyway, I was working at one of our community hospitals one day, minding my own business, when I got a phone call from a local nursing home. And I was told that there was a 54-year-old woman who was in the nursing home who has a history of cancer, metastatic cancer, who had a syncopal episode, and she was being sent to the emergency department for evaluation of the syncope. So I love syncope, and I was ready with the EKG machine as soon as she arrived. And when she got there, we got a quick 12-lead EKG. Now, I should tell you that when she arrived, she had a significantly decreased level of consciousness, which I'm told was not her baseline. So technically, that's not syncope, right? Syncope, they're supposed to wake up. This patient hadn't woken up, but I was all set for a cardiac workup on this patient. We got a quick 12-lead EKG, and as you see, there's diffuse T-wave inversions. So clearly, 54 years old, she's got bad protoplasm. She's probably got syncope related to some type of cardiac event. And we got an old EKG, and her old EKG shows that these T-wave inversions are clearly new. So this is her baseline EKG. There's at most just non-specific T-wave flattening in a bunch of leads. And now she's clearly got T-wave inversions everywhere. So I ordered up some aspirin, ordered up some heparin, since it's a pretty concerning EKG showing diffuse cardiac ischemia. And all those things are being placed in, and troponins and CPKs and myoglobins, everything's being sent off. And then the family arrives. And so I'm getting a little bit more history from them because she's pretty out of it. And I'm explaining to them that I'm worried about her heart. She's got these T-wave inversions, and it's possible that she's just not perfusing her brain well, and so we're going to take care of that. And the family gives me a little history, and they say, well, you know she's got metastatic cancer, right? And of course, I knew that already. And then they said, well, you know she's got mets to the brain too, right? And I said, of course I do. I'll be right back. And then I ran into the room, and I told the nurse, don't start the heparin. We need to get a CAT scan. Fortunately, they had not yet started the heparin on this patient. And with mets to the brain, we're not going to start any anticoagulants. So we sent the patient for a CAT scan, and sure enough, this patient had a big intracranial bleed as the cause of her pseudosyncope, and also as the cause of her T-wave inversions in all of these leads. So it's kind of an interesting finding, and in the remote recesses of my brain, I think I recall at the time hearing that intracranial bleeds and CNS events can cause some EKG abnormalities. So I went and looked it up, and it turned out that this diffuse deep T-wave inversions, and especially with these long QT intervals, so diffuse T-wave inversions with long QT intervals, it turns out was, dare I say, classic, but fairly classic and very well reported for patients presenting with significant intracranial bleeds. Now, let me just review something that we've talked about before in this video series, the causes of prolonged QT. We really focused previously on hypoelectrolytes, but we kind of glossed over the fact that intracranial bleeds and elevated intracranial pressure can prolong the QT as well. And it's a very important part of that differential for a prolonged QT. Now, let me just say that you don't need to CAT scan everybody with the prolonged QT, but if you've got somebody who's got an altered level of consciousness, especially a decreased level of consciousness with a prolonged QT, you've really got to worry about some type of intracranial process that's increasing the intracranial pressure. Not only intracranial bleeds, but this has also been reported, and I've also heard people telling me about cases of patients with cerebral edema from hyponatremia, or some elevated intracranial pressure from an unruptured subarachnoid aneurysm. That's actually reported in the literature as well. So anything that's elevating intracranial pressure can flip those T waves, make them gigantic T waves, and prolong that QT. And in fact, this is so well reported that Marriott and some others would refer to this as cerebral T waves. And when I was in residency, Edward Chung, who is an electrocardiography guru, really one of the most well-published EKG cardiology folks ever, would oftentimes refer to these as roller coaster T waves because they look just like a roller coaster. The T wave goes up and then very, very downwards, very, very steep, and then back up, and you'll notice that there's a prolonged QT there as well. So keep that in mind in the differential for prolonged QT, especially when you see those deep T wave inversions. Now, if we talk more generally about what type of EKG abnormalities can occur in the presence of elevated intracranial pressure and especially intracranial bleeds, and also I should say under CNS events, this can include ischemic strokes as well. Well, diffuse T-wave enlargement and inversions are very common. So you get these very deep, the roller coaster T-waves, okay? But you can also get Brady or tachy dysrhythmias. Perhaps Brady dysrhythmias and AV blocks are more common than tachy dysrhythmias. So definitely Brady dysrhythmias, also non-specific ST changes is in the differential for everything, and even ischemic ST changes. These are not that common, but I've seen this reported in the literature as well, and I think once in my past 18 years I've seen a patient that came in with ST segment elevation in some leads and what looked like reciprocal depression in other leads, and for all the world you would swear that this patient was having STEMI with reciprocal changes, and it turned out to just be an intracranial bleed. So sometimes people refer to CNS events as the great imitator on electrocardiography. Just like hyperkalemia can produce just about anything, just like myocarditis can produce just about anything, so too can CNS events. They can produce just about anything on that 12-lead EKG. Please remember this, and also remember this. This is not that common, but you've got to be on the lookout for it. And these diffuse T-wave enlargements and inversions, those, I'm not going to say pathognomonic, but I would say if you've got somebody with a decreased level of consciousness who's got these roller coaster T waves, you're looking at a patient with a head bleed or some other cause of elevated intracranial pressure until proven otherwise. You get a CAT scan on those patients before even giving them aspirin. That might be conservative, but certainly before giving that patient heparin or anything else. Let me show you a couple more EKGs just to really hammer this home. Here's another patient that I took care of a handful of years ago. Diffuse T-wave inversions. All of these T-wave inversions were new. These are not that deep, but for whatever reason, in the precordial leads, that's where you get those roller coaster T-waves, deep T-wave inversions with the prolonged QT, those roller coaster T-waves, and in many cases, they can be 10, 15, 20 millimeters in depth. Take a look at these. Very deep, very, very prolonged QT, very deep T waves, those roller coaster T waves in the precordial leads, and milder T wave inversions in the limb leads, but roller coasters in the precordial leads. Here's another one, and this patient also had an intracranial bleed and decreased level of consciousness. Huge 15 to 20 millimeter T wave inversions, those roller coaster T waves, very deep, very inverted, and a prolonged QT. When you see these type of T-wave abnormalities in patients that have any altered level of consciousness, get the CAT scan immediately. That patient's got a head bleed, and do not give that patient any type of anticoagulants. And again, this is another pseudo-ischemic pattern. We've talked about some of those before. Not everything that flips your T-waves is ischemia. And that's what I was thinking when I saw that patient that we started with. I thought, well, new T-wave inversions, what else produces flip T-wave inversions but cardiac ischemia, right? Let's get the aspirin and heparin on board. Well, I learned something out of that case. Unfortunately, the heparin had not yet started, but intracranial bleeds can produce ischemic-looking T-waves. What's different about intracranial bleeds versus ischemic T-waves is, number one, most of these patients are going to have an altered level of consciousness, and in terms of the EKG, number two, intracranial bleed or elevated ICP causes of flipped T-waves are almost always going to produce a markedly prolonged QT, and sometimes tremendous T-wave inversions, big roller coaster T-waves, whereas ischemia T-waves generally are not associated with a really long QT, and usually those T-wave inversions are not nearly this type of size. They're not roller coasters. They're much smaller hills, okay? And also, as a more general concept, again, remember that intracranial events can produce all kinds of ischemic-looking EKG findings. I know I'm going to get emails asking for why this might happen, and there's really not good literature saying exactly what's going on to produce these flip T waves. Some theories that I've heard some people say that marked elevations in intracranial pressure can produce a sudden surge of catecholamines, and those catecholamines produce the ischemic changes. I've heard other people say that these marked elevations of intracranial pressure can produce a vagal response, and that can produce ischemic changes. In my mind, that can produce the bradycardias and AV blocks, and maybe, well, I'm not really sure why that would produce these T waves. And then one other theory I actually read about was from a paper back in the 1960s. Yeah, so I clearly need a life. But anyway, I was reading that paper from back in the 1960s, and the author was actually showing some data based on, I guess, autopsies, that patients with marked elevations in intracranial pressure can produce sudden increases in left ventricular pressure in the heart, and that can produce subendocardial hemorrhage. And so his point was that his point was that CNS events don't produce EKG changes that mimic cardiac ischemia, but in reality, elevated intracranial pressure and CNS events can actually induce true myocardial injury with these small subendocardial hemorrhages. And so given that there's real myocardial damage, that's what actually produces the EKG abnormalities. So anyway, whatever the reason is, out of various theories, whenever you hear more than 2 or 3 theories, it means nobody really knows what the heck's going on, and that's probably the case here. Whatever the true reason is, please remember that CNS events can produce EKG abnormalities that mimic ischemia, and especially when you see T waves that are looking like that, that person needs to get a CAT scan yesterday. That person needs a CAT scan immediately. So just be very, very careful about that. Anyway, I hope that was helpful, and I look forward to talking to you next week. Bye for now.